Hello everyone. So today we will be learning about the second part of Introduction to General Surgery. We have already done the part one, and in this part we will be learning about the preoperative, intraoperative, and postoperative phases of surgery, and what is surgical team structure and what are their roles. And in last we will be learning about the common surgical conditions and their management. So, preoperative, intraoperative, and postoperative phases. Now, preoperative phase is basically it is a period before surgery where patient evaluation and preparation takes place. So whenever patient is being ready for the surgery, that phase is known as preoperative phase. This phase is before entering the operation theater. So what are key steps in the preoperative phase? First of all, patient assessment is being taken. In patient assessment, we take proper medical history of the disease and physical exam, proper examination is being done along with lab works, which are important, like blood work in which we do CBC, UCEs, LFTs, and PTINR, and urea creatinine. And ECG is also done to evaluate any kind of heart condition. Chest X-ray is again very important. You have to see any lung abnormality before in the induction of anesthesia. And again, in the patient assessment, risk stratification according to ASA classification is also evaluated, which patients will be benefited and which patients have the greater risk for any kind of complication. Secondly, informed consent is taken from the patients, in which a patient is explained about the procedure of the surgery and its risks and its benefits and any kind of alternatives you have for the surgery. And preoperative instructions are very important in the preoperative phase. Firstly, you have to tell the patient about NPO guidelines, which I'll be sharing with you in the next slide. Uh, and again, he or she is taking any kind of medications, you have to adjust those medications, which we will be reading in the next few slides. And then you have to prepare the patient for the surgery. His skin should be properly prepared with the antiseptics like chlorhexidine and pyodine. And uh, few preventive measures are very important for the pre-op phase. Like you should be giving patient the antibiotic prophylaxis, and if that patient has any kind of DVT risk, you should be giving the DVT prophylaxis. So overall, the goal for preoperative phase is basically you have to ensure a patient safety and optimize surgical outcomes. Now, these are NPU guidelines according to ASA recommendations, and the ASA is basically American Society of Anesthesiologists. So these are basically preoperative fasting guidelines. That means the patient is allowed according to the time for some liquids and for some solids. Like the patient can take clear liquids up to 2 hours before the start of surgery. And you see, breast milk should be taken 4 hours before the start of surgery. Infant formula milk should be stopped 6 hours prior to surgery. Non-human milk should be stopped 6 hours prior to surgery. Light meal like toast and clear fluid should be again stopped prior to the 6 hours of the surgery. Now, these fried and fatty foods are heavy meals. They should be, the patient should not be taking these heavy meals uh, up to 8 hours before they start a surgery. So overall, NPO guidelines, we recommend to the patient that he or she should not be taking anything like 8 hours before the surgery. So, what is the importance of these NPO guidelines? Basically, it reduces the risk of aspiration during anesthesia. Let's suppose a patient is taking any kind of liquid or any kind of fried or fatty food, and then you are inducting the anesthesia. Then patient like there are side effects of few drugs, and patient is having nausea or vomiting, so as he will vomit those liquids or any food particles, but he's unconscious. So what will be the impact? That patient will aspire that liquid and that food into his lungs, and that can again cause death. So these were the NPU guidelines. Now we come to the preoperative medication management, and like anticoagulants in the are very important. You have to stop those drugs because they are the blood thinner. They can cause massive blood loss. So these are few medications which should be hold before the surgery, like warfarin. If any patient is taking, that should be hold for 3 to 5 days, and you have to continuously monitor INR for that patient, and it should be less than 1.5. Direct oral anticoagulants like dabigatran, rivaroxaban, and apixaban should be hold for 2 to 3 days, and you have to see for renal function too. Heparin, like IV, it should be hold for 4 to 6 hours before the surgery. Aspirin, if any patient is cardiac stent, it should be continued. Otherwise, it should be hold for 7 days. NSAIDs again, 1 to 2 days. They should be in hold, but again there is bleeding risk if you're holding the NSAIDs. Metformin again, if any patient is diabetic and taking this metformin, he should be holding that medication for 24 to 48 hours, and after pre-op you can resume the metformin. ACE inhibitors and herbs for hypertension, they should be hold for 24 hours. Again, there is a risk of hypotension if you're giving them before the surgery or during the surgery. Diuretics should be stopped at the morning of the surgery, and diuretics, if you are giving them, they can cause electrolyte imbalance. And now, low molecular weight heparins that are used for bridging therapy, they should be used if patient is high thrombotic risk, any patient. So you can use then low molecular weight heparins. So this was a preoperative medication management. That was all about the preoperative phase. Now we come to the intraoperative phase of the surgery. And now this is basically time from entering the operating room to surgical closure of the patient. So the patient enters the OT room, and then this whole surgery takes place. Then you close the final wound or final in anything you're doing on the patient. That surgical closure is being done. That is the intraoperative phase. So, what are key components in the intraoperative phase? First of all, when patient is in OT room, there are team roles. Like there's team of doctors in the OT room. There will be surgeon, there will be anesthesiologist, nurses will be there, and script technicians will be there. And when patient is in the OT room, the first thing that will be done is an anesthesia administration. And there are three kind of anesthesias we administer to patient. One is general, other is regional, and local. I'll be defining each of them in the next slide. Surgical steps are again very important in the intraoperative phase. Incisions are taken, dissection of tissues is done, and then hemostasis is done to reduce the blood loss, and whatever the surgery you want to do, any kind of repair you do, you just do that repair, and after that you close the patient. So again, intraoperative phase, sterility and safety must be ensured at each and every level. Aseptic techniques again are very important. They should be practiced at every point. Instrument counts again. You have to count instrument because you sometimes there's this mistake being done by a few nurses or doctors. They left the instrument in the abdomen or in the body of patient, and patient positioning is again very important. So during this all intraoperative phase, monitoring of patient is of very pivotal role. Like vital signs of the patient should be monitored all the time. His BP, heart rate, and saturation should be maintained at the optimal range. Blood loss is again, it should be monitored very well. If patient is having massive blood loss, Blood transfusions should be done, and the anesthesia depth or anesthesia's overall monitoring. So, what preventive measures you can take during intraoperative phase? You should be having the sterile techniques all the time, and you should be having the careful hemostasis. So, this is the comparison of anesthesia types. Now, basically, general anesthesia is some kind of a in which patients are made unconscious. So, it requires a ventilator support. Overall, patient takes breathing or takes oxygen from the ventilator. While regional anesthesia is basically a nerve block in which you block the spinal or epidural nerves, and it usually block or it usually anesthesize only one limb or any limb you want to block. Local anesthesia can be given by lidocaine, bupivacaine, or procaine along with the epinephrine. Local anesthesia is will be blocking or making the pain-free few area or any small area in your body. Now, if we come to the comparison between these three, these are the parameters which we will be comparing between these among these. So consciousness, basically in general anesthesia, patient is unconscious, but regional anesthesia, patient is awake, but he's sedated, and local anesthesia, patient is fully awake. Pain coverage is very important. In general anesthesia, pain coverage is for the whole body. In regional anesthesia, a large region like limb is covered for the pain coverage, and local anesthesia, smaller specific areas. Duration, general anesthesia can continue for hours and it is controlled. And regional anesthesia is for hours and it is usually given as a single dose or it can be given through a catheter. And local anesthesia is basically for a smaller span of time, and it continues for minutes to 2 hours. Again, with risk level is very high in general anesthesia because you have to manage the complete airway, and there can be risk of any aspiration or anything further. Regional anesthesia has a moderate risk factor. The risk can be of nerve injury because you are injecting nerve blocks, so nerve can be injured. And in local anesthesia, the risk level is very lowest. So, where these anesthesias are basically used, general anesthesia is used in major surgeries like heart and hernia repairs. Regional anesthesia is we commonly use for C-sections, joint replacements, and local anesthesias for the dental work, sutures, or any kind of local lipoma removal, abscess removal, or anything else that requires the local anesthesia. So now we come to the post-operative phase, and this period is basically when you complete the surgery and until the full recovery of that patient. That is the post-operative phase. So um, during post-operative phase, there are key stages. One is a patient can be recovered immediately. So at that moment, you have to just monitor his vitals and give medications for pain control. And at the after when completion of surgery, patient usually has the feeling of nausea. So you have to manage nausea. If that patient is staying in your hospital, in the post-operative phase, you should be caring his wound and doing daily dressing and maintaining the cleanliness of that wound. And ambulation is very important. You have to ask the patient to ambulate himself, and after their diet progression, you have to counsel the patient regarding the diet progression. When you are discharging the patient and telling them for home care, you should be telling them instructions on activity restrictions and how the medication should be taken and any kind of complication that is happening to him. He must be reporting to the doctor. So these are important stages in post-operative phase, immediate recovery and hospital stay, discharge, and home care. Now. Uh, In the post-op phase, there are few complications which should be monitored at all the time. Infection is very important. It can be after the surgery. Bleeding is again a very common complication, DVT and pneumonia. So any kind of this complication is happening to patient, he must be counseled to return back to doctor. And preventive measures during post-op phase should be you should be asking for the patient for early ambulation, and wound care is very important. Uh, in post-operative phase, we do follow-ups for the patients too. We schedule visits to assess healing and functions of the uh, uh, parts we have done surgery on. So post-operative diet progression is very important for patients because at few instances patients start taking all the things after surgery and they again cause very serious problems. So post-operative diet progression is basically started in 4 phases, and so patient is in that phase patient is allowed few things and prohibited for few things. Like in phase 1, this a patient should be allowed to take clear liquids like water, broth, apple juice, or gelatin, and you have to monitor patient if he is tolerating these clear liquids for 4 to 6 hours, and he is having no any kind of nausea. Then you can advance to phase 2. Now in phase 2, patients are allowed full liquids like milk, yogurt, pudding, and cream soaps, soups, and you have to see if patient is tolerating that clear liquids for 12 to 24 hours, then you can proceed to phase 3. And phase 3 soft fruits are basically allowed for the patients, in which patient can take mashed potatoes, oatmeal and scrambled eggs, and you have to see if there's no any kind of jet distress on liquids, so patient can be started on the phase 4, in which he will be allowed to take regular diet, like the gradual reintroduction of fiber and proteins. Again, the phase 4 is basically on surgeon approval, and it is most commonly started post-op day like 3 and 4. So this is in short, a patient is NPO. After surgery, you start clear liquids, and then you see if the patient is having no vomiting, you advance slowly. And after abdominal or GI surgery, in all these after surgery, the patient should be counseled for avoiding carbonation and spicy and fried foods early on. Now, what is surgical team structure and their roles? Now, overview of the surgical team. Basically, surgical team is a multidisciplinary team working together to ensure safe and effective surgery. The core members, we all know a surgeon is the lead person. He leads all the procedure, and he has assistant surgeon, which basically assists the lead surgeon. Anesthesiologist is the one who manages anesthesia and vitals of the patient. Scrub nurse and technician, he's the one who handles instrument and maintains sterility. There's also circulating nurse that manages non-sterile tasks and assists team. Now, this team can be expanded, in which you can add more surgical assistants if you need. They can be need a perfusionist for like cardiac surgery. In cardiac surgeries, radiologists are needed in the orthopedic surgeries more commonly. So what is the importance of teamwork? Now they have the clear communication, and they all know their defined roles, and their coordination basically prevent errors. So overall, if we come to the roles and responsibilities of these core members, like surgeon, we know a surgeon performs the operation and he makes critical decisions, and he is the one who leads the team. Anesthesiologist is the one who administers anesthesia, and he is the one who monitors patient vitals, and he manages the pain in at that moment in the operation theater, and also in the post-op recovery. He's the one who will be managing patient. Uh, the nurse is the one that prepares instruments, passes tools to the surgeon, and maintains all the sterile field in the operation theater. Circulating nurse is basically a non-sterilized nurse. He opens, supplies, documents the procedure, fetches additional equipment which are required, during the surgery. Surgical assistant is assistant to the main surgeon, and he aids in exposure, suturing, and retraction, and maybe another surgeon or surgical assistant. So, introduction to common surgical conditions. This is the last topic in which we will be learning about few common conditions that are mostly seen in surgical general surgery field. Uh, Firstly, before going to the common diseases, we must be learning about that surgeries are being done on urgency. Like there are elective surgeries, and there are urgent surgeries, and there are emergency surgeries. Mm. So you must be having knowing the difference between all these surgeries. So elective surgery is basically it is a procedure that is pre-planned and based on patient's choice and availability of scheduling for the patient, surgeon, and the facility. So elective surgeries are basically they are done on patients' time and availability, and also surgeon's time and availability. There's no rush or there's no hurry in doing these surgeries. They can be done at any specified time. Examples are like hernia repair, cataract extraction, tonsillectomy, and hip prosthesis. Urgent surgeries, these are the surgeries that must be done within 24 to 48 hours, and they should be done to preserve the health. Like example of removal of gallbladder, amputation, and appendectomy. They are the urgent surgeries. Emergency surgeries, and they must be done immediately when you see the patient, because you have to preserve a life or any body part or any function. Like these are emergency surgeries are basically done during gunshots or during any kind of disaster happening or any road traffic accident. So if there's massive bleeding going on and you have to control the hemorrhage, you have to do emergency surgery and repair of any trauma perforated ulcers because it will again cause massive blood loss, and intestinal obstruction is again emergency surgery because it can um, cause a death. So you have to do emergency surgery to relieve that obstruction. Now, these are some common surgical conditions and then areas. So surgeries are basically divided into a few categories. In the acute abdomen, you see patients for appendicitis, cholecystitis, and bowel obstruction. And in trauma, patients come for fractures, internal bleeding, and penetrating injuries. Uh, General surgeons basically do surgeries for the neoplasms too, like benign lipomas are done by the general surgeons, malignant like colon cancer. Infections again, abscess or necrotizing fasciitis. These are again done by general surgeons in hernias, inguinal, umbilical, and incisional. Now the first disease we have is appendicitis, and this is very common in young males and young females. Basically, it is the inflammation of appendix due to obstruction. So appendix is just kind of a vestigial organ, and it can have an inflammation due to two main reasons. Either the fecal material goes in the appendix, it will cause inflammation, or there is a lymphoid hyperplasia. Lymphocytes are there, and they can get hyperplasia. So these two will cause inflammation of the appendix. Now, how the patient of appendicitis presents to a doctor? Basically, he has a right lower quadrant pain, and along with fever, nausea, and rebound tenderness. And so these are classical symptoms seen in appendicitis patient. Again, you have to operate it in an urgent in surgeries because the complications again can be very serious. The appendix can be perforated, and it will then cause peritonitis and abscess. Now, how we treat appendicitis, what is surgical intervention in it? Basically, we do appendectomy. Now, appendectomies can be open or laparoscopic. Nowadays, laparoscopic surgeries are also being done, but most commonly, open appendectomy is done uh, overall. So, the key steps in this appendectomy are first of all, you have to give a McBurney's incision in open, or if you're doing laparoscopic, then you have to put three-port laparoscopes. Now, McBurney's incision is basically it is a point from anterior iliac anterior superior iliac spine, and from that point to the umbilical, and between these two areas, there's this McBurney's point, and you have to give incision at that point. And after incision, you have to identify the appendiceal artery, and you have to ligate it, and at the end, you have to close that wound. So again, in the post-op phase, you have to prescribe IV antibiotics to the patient if that appendix you see was perforated. The next most common uh, surgical disease we see is cholecystitis, and it is basically caused by gallstones that basically are obstructing the cystic duct. Now, how cholecystitis presents to us: patient will be having right upper quadrant pain, and he'll be having Murphy's sign and jaundice if the patient is having polydocolichiasis. Surgical intervention. Now, what we do in this cholecystitis, we basically do laparoscopic cholecystitis in patients mostly, and that is basically gold standard. So, in the laparoscopic cholecystectomy, you have a critical steps to do, and uh, right, you should be knowing about the Murphy sign. So it is basically a maneuver during physical examination. It is basically done for differentiating the right upper quadrant pain, and in this, what basically it is for the cholecystitis. So when patient deeply inhales, and if you palpate just below the ribs in the right upper quadrant, the patient will have pain. So this is called Murphy's sign, and it is basically associated with inflamed gallbladder, right? So for cholecystitis, we do laparoscopic cholecystectomy, and in this critical steps are basically the one most important step is Callep's triangle dissection. You have to identify cystic ductal artery. We will be learning about Callep's triangle in next slide. And alternatives can be for this cholecystitis, open cholecystectomy for severe inflammation. Otherwise, laparoscopic cholecystectomy is gold standard. Now, this is Caleb's triangle. You have to preserve this, and you have to be very much skilled to go through this Caleb's triangle. Now, for the what are the key steps during this surgery? You have to first of all expose the triangle boundaries. Like on the medial side, you see common bile duct. So this is basically common bile duct. This is on the medial side. This is common bile duct. And on the lateral side, you see cystic duct. This is cystic duct and gallbladder infundibulum. So this is cystic duct. And on the superior side, you see these liver edges. So in this triangle, basically you see this right hepatic artery, and also is going a cystic artery. So, what are dissection principles? Basically, you have to strip the fat or lymphatics, and you have to reveal the cystic duct and cystic artery, right? So, these are the important structures. You see, this is cystic duct and this is cystic artery. You have to reveal them, and you have to achieve CVS, that is critical view of safety. Only two structures enter gallbladder, that is cystic duct and artery. These are two structures that enter the gallbladder. So you have to avoid the pitfalls during all this, because there can be misidentification. Like you can identify CBD, common bile duct, as a cystic duct, so it will be causing major problems. And you, for reducing the blood, you have to having the good knowledge of anatomy. So this was about the Calais triangle, and it is important for doing surgeries on the gallbladder. Inguinal and umbilical hernias. Inguinal hernias are again, these are the bowel protrusions through inguinal canal, and these are indirect and direct. This is basically about sorry for the pause. And inguinal and umbilical hernias are basically these are the protrusions of the bowel or any kind of tissues from the your inguinal canal or your abdomen. So inguinal hernias are basically these are bowel protrusions through inguinal canal, and these can be direct or indirect. Umbilical hernias are basically defects at the umbilicus, and again, these hernias basically have a risk of strangulation. Again, in strangulation, and the arteries are strangulated, and there can be this risk of ischemia. So, what we do for these hernias, we do surgical interventions like this process of herniorrhaphy, in which the hernias are repaired, and hernioplasty, uh, in which mesh is placed in that area of hernias. So what are the approaches? There can be two approaches: open approach, Lindstein's approach, and laparoscopic tap or tape approaches. So what basically key is to reduce hernia sake and reinforce that posterior wall. You have to reduce those hernia content back into the abdomen or back into the that region, and you have to support or reinforce that posterior wall with the tissue repair or any kind of mesh. So, we should be learning about the types of hernias. There are typically seven types of hernias, and we will be briefly defining these hernias on the basis of these three features: location, key features, and clinical pulse. Like inguinal hernia are the hernias that are from the groin region, inguinal canal, and they are the most common hernias in specifically males. And again, as I told you, inguinal hernias can be indirect or indirect. Indirect is hernia that is lateral to the inferior epigastric vessels, and direct hernia is basically medial to the inferior epigastric vessels. Femoral hernia is below the inguinal ligament, and the key features for femoral hernia is basically it is more common in women, and it is a high strangulation risk. And so you see a palpable lump in upper thigh when the patient is having femoral hernia. Umbilical hernia is located in the umbilicus, and it is basically common in infants and obese adults, and in children it is usually self-resolving. And incisional hernia is uh, basically happens on the previous surgical scar, and it is usually a late complication, a post-op complication, and incisional hernias usually require mesh repair. Hiatal hernias occur through diaphragm, in which stomach can protrude through the diaphragm, and it can cause hiatal hernias. And you will be having the symptoms of GERD, like heartburn, and if that hernia is paraesophageal, it is a surgical emergency. You have to do it in emergency. Epigastric hernias are basically between umbilicus and xiphoid process, and in this fatty tissue basically protrudes, and it is often painless. Stiglin hernia is basically a hernia in the lateral rectus sheath, and it is usually rare, and no any kind of bulge and until it is strangulated. So it is some kind of hernia suspicion. So this is picture you can appreciate from here. This is epigastric hernia, and between xiphoid and umbilical, this is umbilical hernia, and incisional hernia on previous scars, Stiglian hernia, this is femoral hernia, and inguinal hernia. A bowel obstruction is again very common in surgery, general surgery field. There can be different causes for bowel obstruction. Causes like adhesions, these are the most common causes, and tumors can cause bowel obstruction in volvulus. So symptoms are very typical of bowel obstruction. Patient will have a distension of the abdomen. He will be having vomiting, and if anything, he's taking, and there'll be obstipation because patient will not even pass any kind of gas. Now, what we do in the surgical intervention, we do exploratory laparotomy or laparoscopy. So in this, let's suppose the patient is having adhesions. So we do adhesiolysis or resection for necrotic bowel wall, and also if there is a bigger obstruction, we do primary anastomosis or ostomy. I'll be telling you about these two in the next slide. So in the post-op, you should be giving the nasogastric tube decompression until bowel function resumes. Now, these are two important surgical processes. One is primary anastomosis and other is ostomy. Now, primary anastomosis is basically uh, after removing the diseased portion of intestine, the two healthy ends are directly connected. It can be sewn or stapled together. So if you're removing that obstructed part and then you connect those two parts with each other with any kind of staple or they are sewed together. On the other hand, ostomy, in which colostomy or ileostomy is done, instead of reconnecting, the surgeon basically brings the end of intestines out from through the abdominal wall to create a stoma. Stoma is like a hole, or you say. So basically, it creates a stoma, and a stool exists into a bag attached to that stoma. So these are so now what are the indications for these two processes? Like for primary anastomosis, the patient must be stable and he should be having minimal contamination, and it basically is used for healthy bowel edges. Ostomy is done for unstable patients, and the patient is having severe peritonitis, and there is high risk for anastomosis. Now, advantages again, you have to see in the primary anastomosis, it is basically a single surgery. Once done, you will be not reoperating on that, and no stem or base is needed because again the intestines are connected to each other, and it is faster recovery, and the patient will be having natural bowel function. Like in the ostomy, it basically diverts fecal stream because you created a stoma, a hole in the abdomen, so the stool will come into the stoma bag, and but it has a lower leak risk, and once you do any re-exploration, it will be easier. Now, disadvantages for these two processes that for primary anastomosis, there is a higher leak risk if conditions are suboptimal, and there can be a reoperation if it fails. But in the ostomy, stoma care is again the big headache for patients if they are on which ostomy is done. And second surgery for the is always done for the reversal. And again, the body images are concerned because always there will be a stoma bag attached on the abdomen. Again, general surgeons are the one who treat breast cancers, surgeries for the breast cancer. If you come to the breast cancer, there are three types of breast cancer: ductal, that is most common, labular, and inflammatory. For diagnosing the breast cancer, we usually do mammogram, then do biopsy and the hormone receptor testing for initiating the treatment. And surgical intervention, there are these three procedures. One is lumpectomy, in which tumor is excised and radiation is started on the patient for continuing the breast function. And basically, lumpectomy is breast conserving surgery. Mastectomy is basically simple modified radical, and in this you remove the breast along with lymph nodes. Sentinel lymph node biopsy is basically done for axillary node assessment. Now, mammogram, if we come to this, is basically an X-ray imaging of breast tissue to detect abnormalities like tumors or microcalcifications. And it can be done as a screening tool or diagnostic tool. And in screening, we do on asymptomatic women for early detection. For diagnostic purposes, we do symptomatic or follow-up for abnormalities. It is important to understand when you have to screen for the mammogram. Like general guidelines says, any woman of age 40 annual, she should be going for the mammogram annual or biannual. But those women who are high risk, like BRCA positive, these are the genes, and there's a family history of breast cancer, they should start earlier for going to the mammogram, like at the age of 30. Thyroid nodules cancer, again, thyroid surgeries are important part of general surgery field. Nodules can be benign, like colloid, and malignant papillary or follicular. These are the Types of thyroid cancers. Uh, Basically, when you do surgeries for thyroid cancer, when there's hoarseness or there's rapid growth of that thyroid cancer, and the surgical interventions you do is basically you do thyroidectomy. Now, thyroidectomy can be total or hemithyroidectomy. And in this thyroidectomy, the key steps are you have to identify the recurrent laryngeal nerve because damage to recurrent laryngeal nerve can cause hoarseness, and damage to parathyroids can cause hypocalcemia. So, and any kind of frozen section for the malignancy. Complications, again, as I told you, if you damage recurrent laryngeal nerve, the hoarseness will be there, and if you are removing the parathyroids, the symptoms of hypocalcemia will occur. Now, if we compare the total versus hemithyroidectomy, and these are a few comparisons. Total thyroidectomy is basically complete removal of thyroid gland, and hemithyroidectomy is basically removal of one lobe plus isthmus. Now, for total thyroidectomy, indications are usually there if the patient is having thyroid cancer, Graves' disease, a large multinodular goiter, you should be doing total thyroidectomy. While hemithyroidectomy is for single benign nodules and any indeterminate nodule you are performing, you are knowing for the diagnostic purposes, and any kind of low risk unilateral cancer. Advantages for total thyroidectomy are basically it is definitive treatment for any cancer and no recurrence in removed tissue. Hemithyroidectomy basically preserves the thyroid function and there's lower complication risk. Now, disadvantage is that if you are removing the thyroid tissue completely, the patient should be started on levothyroxine for the lifelong, and there's higher risk for hypoparathyroidism and recurrent laryngeal nerve injury. For hemithyroidectomy, there's possible need for completion of thyroidectomy because there's a residual disease risk. Again, complications of thyroidectomy are hypocalcemia and bilateral recurrent laryngeal nerve injury, and hemithyroidectomy, unilateral right recurrent laryngeal nerve injury can happen and hematoma can be formed. If we now come to the hypocalcemia and hypercalcemia, now basically total normal serum calcium levels are 8.5 to 10.2 milligram per deciliter. Now, hypocalcemia will happen like low calcium when the calcium level in a blood is less than 8.5. So, how hypocalcemia will present? The patients will be having mm, two important symptoms, like symptoms from the neuromuscular areas and the cardiac symptoms. Patient will be having paresthesias like tingling in the lips and fingers, muscle cramps and tetany will be there. This Chostek sign is very important that when you touch patient's face, there will be facial twitch. And the Trousseau sign is basically carpopitular spasm. When you apply a BP cuff on the arm, the patient will be having a spasm. And in the cardiac symptoms, the patient will be having prolonged QT interval and arrhythmias can happen. Other symptoms in the hypocalcemia are seizures and brittle nails are here. Hypercalcemia is basically a calcium level greater than 10.2, and patients of the hypercalcemia basically present with fatigue, lethargy, muscle weakness, confusion, or depression. And in the cardiac, they have usually shortened QT interval. They'll be having hypertension and bradycardia, and other symptoms are basically polyuria, polydipsia, and kidney stones. Colorectal cancer is again the surgeries which are done in the general surgery field. Uh, colo Cancers can be in the left colon and right colon, and can be in the rectum. So once the diagnosis is made, the staging can be done through CT and CEA, and then the colonoscopy is done. Now, surgical intervention for the colorectal cancer is right hemicolectomy is done for cecal or ascending tumors and low anterior resection. That is done for rectal cancer in which sphincter is basically spared and the sphincter function is normal. Hartmann's procedure is basically it is an emergency procedure for whenever there is a perforation due to colon cancer. Spleen or liver trauma, again, these are common in gunshot and RTA patients, in which, first of all, grading is done. Grade 1 is mild, and grade 5 is devascularization of whole spleen and liver. Symptoms basically is that the patient's having shock, care sign is also positive in the spleen, right upper quadrant pain in the liver. Surgical interventions we do for like splenectomy we do for grade 4 and 5, and you have to vaccinate the patient for post-op for the encapsulated organisms like Neisseria meningitis, Ashinfluenza, and pneumococcus. You have to vaccinate these patients after you remove the spleen. In the liver, you do packaging, resection, or angioembolization, and you should be doing the hemorrhage control or damage control surgeries in these spleen or liver traumas. So now we come to the clinical scenarios in which we will be reading about the scenarios which can come in your exams, and whatever you we have just learned, we can analyze through these clinical scenarios. So in clinical scenario number one, this is during a laparoscopic cholecystectomy. The scrub nurse notices the surgeon accidentally contaminated their glove by touching the anesthesiologist's unsterile keyboard. The circulating nurse is unavailable and the patient is hemodynamically unstable. So what is the most appropriate immediate action? So in that moment, what you will be doing? Continue surgery to avoid delays since the patient is unstable. Break sterility to replace the contaminated glove yourself. Verbally alert the surgeon and wait for the circulating nurse. Use antiseptic wipes to clean the glove. So there's a break in sterility. The main and the most important thing during the operation theater during the surgery is basically you have to maintain the sterility. So the answer will be B. You have to break the sterility to replace the contaminated glove yourself. Because non-sterile team members can assist in emergencies to maintain sterility, the glove must be replaced. In second clinical scenario, a diabetic patient, HbA1c is 9, undergoes open appendectomy for perforated appendicitis. On post-operative day 3, the wound is erythematous with virulent drainage. Which intervention most likely could have prevented this? So it is basically pre-operative, and they're asking about pre-operative phase of this scenario, what we would have done to avoid this. So pre-operative chlorhexidine shower, intraoperative wound irrigation with saline, post-operative hyperglycemia control target 1 less than 180 and using monofilament sutures. So basically they are asking about what could have been done to prevent this. So basically HbA1c is 9, this patient is diabetic, so glycemic control is very important while pre-op, in intra-op and post-op phases. So option C will be right. We have to tie the glycemic control because it reduces the surgical site infections more than any other options. Clinical scenario 3 is basically during a total knee replacement, the surgeon's sleeve touches the unstable operating light. What is the minimum required action? So again, the stability is broken. Now what you have to do, change gown and gloves, apply iodine solution to the sleeve, cover the contaminated area with a sterile drape, and no option needed, the sleeve is moisture repellent. Again, stability is broken, so you have to change gown and gloves. So any breach mandates full gown and glove change. So these are the references I have put from where I have taken the text, and also the references for image. And this was all about the introduction to general surgery, history, scope, and fundamentals. Thank you so much.